Okay, so let me begin. Um, the topic, as Professor Ayako introduced, this is about the responsiveness of low and middle income country health systems. And what I'm going to do today is to talk about the challenges, talk about the opportunities that us focus on responsiveness of health systems allows us um, to to engage with and to respond to. So before we start, I would like to reiterate what Professor Ayako said. At different points in the presentation, different points in the lecture, if any of you has got any questions, any of you would like to raise and share a thought, I suggest feel free to interrupt me. If I'm in the middle of speaking and I'm in the middle of making a point, I will finish it and then I'll give the floor to you so that we can have a dialogue as required, and you don't have to collect all your questions. You don't have to collect all your thoughts till the very end. Another possibility would be to raise your hand, and Professor Ayako could um, interrupt me and say, "Hey, Sumit, there is somebody who would like to ask a question at this point of time." So that's one. The other bit is that I will also pause at different points of time, at least 2 or 3 times, I would say, to solicit your thoughts and questions, so that if anybody has collected some thoughts and questions, that would be a moment to say, okay, you said this, can we hear a bit more about it? So this is how I foresee the lecture, the session proceeding. Of course, there is earmarked time at the very end to systematically ask questions that you may have collected and haven't asked them in the middle of the lecture. So let's begin. Let me begin by talking about something that all of you, many of you who work in the field of public health, in the field of health systems, are aware of. We know that the World Health Organization around the year 2000 introduced this idea of health systems as consisting of a bunch of building blocks, and it talked about the overall goals of a health system. The overall goals being improved health in terms of level and equity, improved efficiency and performance of health systems, social and financial risk protection, and responsiveness. So those of you who have been wondering, hey, what is Sumit going to talk about? I'm going to talk about one of the goals of a health system. No matter where in the world we might be, we are all working towards this particular goal. Now, the thing is, even if this has been an appreciated, a recognized, widely accepted goal of the health system all over the world, of all the goals, the 4 goals, this particular goal tends to be the most under-researched. This particular goal tends to be the least explicitly tackled in public health policy and practice. And this is what Professor Ayako said actually when she was introducing me. This is what I'm interested in. The argument here is that we are reaching a stage in many low and middle income country health systems where we need to start focusing also on the responsiveness of the health system. So the argument I make in this presentation, and the argument on the basis of which I have, and I'm working towards developing this program of work and research, is that low and middle income country economies and health systems are evolving. The argument is that over the last few decades, we have worked hard, and in most parts, particularly the low middle to middle income country health systems, availability of services is no longer an issue. Accessibility of services is also no longer an issue. In some cases, geographical access might be an issue, but by and large, availability and accessibility related concerns are being slowly resolved. And citizens' expectations from their health system are also changing and evolving. People are expecting more. People want services to be good. People want services to meet their expectations. And we will come back to this idea of expectations at multiple times in this lecture as I develop these ideas further. These transitions, the economic transitions, the epidemiological transitions, the transitions within health systems in terms of availability improving, in terms of accessibility improving, requires a change in the way low and middle income country health systems operate. It also requires a change in the way we as health policy and systems researchers working in global health approach our inquiries. I argue throughout this presentation that these changes, these transitions, present some really unique challenges and opportunities for researchers. They, of course, present a whole lot of challenges for policymakers and practitioners, which many of you graduates of your master's programs will go on to become. And this is what we are interested in tackling in this session. The objectives of the lecture, the objectives of this session are to understand and unpack the concept of a responsive health system. Some of it you will realize as I speak and as I go through this is fairly intuitive, but we will still go through it systematically. We will also discuss some adjacent concepts which are very close to the idea of a responsive health system. Once we've done that, we will discuss some challenges and opportunities around operationalizing, translating the idea of a responsive health system into policy and practice, and in researching health systems responsiveness. The challenges around researching are not limited to researching this subject, this concept within low and middle income country health systems. This applies to all contexts, I would say. The challenges and opportunities around operationalizing in policy and practice, however, because my expertise is in low and middle income country health systems, I think I can only speak to it from that particular starting point or vantage point, if you may. We will also briefly reflect upon some dilemmas entailed in comparing and researching the responsiveness across and between different health systems. Let's begin at the beginning. I share with you here, and I would like you to spend some minutes, maybe some seconds, to read this carefully. This is how the World Health Organization has defined responsiveness. The one of the 4 goals of the health system. They talk of responsiveness as the outcome that can be achieved when institutions and institutional relationships are designed in such a way that they are cognizant of and respond appropriately to the universally legitimate expectations of individuals. Now, this is a handful, this is a mouthful, and in this session, we will unpack this definition. We will unpack these ideas, the ideas that are introduced in this definition. We will return to this definition and different aspects of it in detail throughout this session. Let's begin, however, with some adjacent concepts first. Let's talk about the kinds of words that are commonly used, that commonly come up in discussions when we are talking about responsiveness. And 2 concepts particularly stand out. That is quality of care and patient satisfaction. Quality of care can cover a wide spectrum of things. And while we cannot possibly cover this topic as a part of this session, some points are really worth highlighting. We can distinguish between structural quality, which refers to things like dimensions like continuity of care, costs of care, accommodation, the physical accommodation, accessibility of services. We can also talk of process quality, which involves the dimensions of things like courtesy, politeness, sharing of information, autonomy to patients and decision making. It also can also relate to the competence of providers, both technical competence and also the social competence, cultural competence, as is sometimes being called. We can also talk about, within quality of care, service quality. People like Kanagi and Beric refer to a set of issues including communication, signposting, information provision, and the interaction of staff with patients while referring to what they call service quality. As part of your studies in public health and more generally in health services, you might have heard the name of Dona Bedian. And Dona Bedian talked about 40 years ago, actually, in 1980, he considered interpersonal aspects of quality of care and amenities of care alongside the technical aspects of quality of care to be the important components of quality within healthcare settings. He talked about the interpersonal quality being defined as the quality of interaction between patients and providers, or the friendliness, the attentiveness of healthcare providers. And the literature suggests that the aspects of personal interactions in the quality of care literature are quite close to, are quite overlapping with the ideas of respect and dignity that we will see are talked about in the concept of responsiveness. So this is a sort of broad snapshot, and there are books written about it, about the idea of quality of care, but particularly the interpersonal aspects of quality of care are quite adjacent to the idea of responsiveness, as I'll come back to later. Similarly, the idea of patient satisfaction has many overlaps with the notion of the concept of responsiveness. Patient satisfaction represents a complex set of things, and it's a mix of perceived needs that people have, perceived expectations and expectations that people have, and also the kinds of experiences people have. It's a very personal thing. I am satisfied, you are satisfied, I might be satisfied, you might not be satisfied with the same service, the same interaction, this lecture perhaps, or the lectures before this, the whole seminar series or the whole lecture series. It's a very personal thing. And these two, patient satisfaction and responsiveness, are quite close to each other. And if you look at the definition of responsiveness, and we are returning to the definition of responsiveness, certain things stand out. Responsiveness is, and we can compare this constantly by distinguishing between responsiveness and patient satisfaction. Responsiveness is different from patient satisfaction and quality of care, and along three broad lines. In terms of its scope, patient satisfaction focuses on the clinical interaction in specific healthcare settings, whereas responsiveness evaluates the system as a whole. Yeah. In terms of range, patient satisfaction generally covers both medical and non-medical aspects, whereas responsiveness focuses only on the non-health enhancing aspects of the health system. Now, if you look at the definition, you will notice these things. Responsiveness is about institutions and institutional relationships. It's about the design and functioning of institutions and institutional relationships. It is about health systems being able to be cognizant of and being able to respond appropriately to the universally legitimate expectations of individuals. It is about the non-medical aspects of care experience and the care encounter. So the rationale is also different somehow. Patient satisfaction represents a complex mix of perceived needs individually determined, all of them individually determined, and the expectations which are also individually determined, and experiences of care which are also about what individuals experience. Whereas if you look at responsiveness as is laid out here, it is about legitimate expectations. Yeah. So whilst this satisfaction tends to look at the system from the provider's perspective, in the case of responsiveness, the emphasis is on the needs of the user of the system, not the individual, but the user at large. And responsiveness, unlike satisfaction, involves an evaluation of the health system against agreed norms. This is what we mean by universally legitimate or accepted expectations. So it involves an evaluation of the health system by individuals and people in society, of course, against agreed norms and standards. Responsiveness moves towards getting individuals to rate their health system against some kind of objectively set standards, rather than evaluate their personal satisfaction. This distinction is important, yeah. And this separation between these two or three concepts: quality of care, satisfaction, individual satisfaction with care, and responsiveness, is important to get. There are a lot of overlaps, but there are some key features of responsiveness that really stand out. And I'll highlight two. Responsiveness is about institutions and institutional relationships. It is about the design and functioning of institutions and institutional relationships. It relates to people's experiences of interacting with their health system, be it with individuals, that is specific service providers, be it specific processes, example, reception, payment of service charges, diagnostic services, or organizational and institutional arrangements like services around grievance redressal, complaining, giving feedback to the organization, and of course also to the physical environment, whether there are facilities appropriate, there's water, there are toilets, and so on and so forth. So this particular institutional relationship locates people's experience at the heart of what entails a responsive health system. So I know I've said quite a bit. From what I've discussed so far, I hope you would recognize that people's interactions with the health system and are a bit different from their interactions with an individual provider, sitting inside a clinic in the middle of a care encounter, and so on and so forth. But you would also start recognizing, I hope, that how people experience this interaction with the health system is also shaped by their individual expectations. Whether, even if we don't want them to, it somehow relates to that. And it is also shaped by their relationships and their background as an individual, as a family, and all of this shapes their expectations. So the notion that becomes key here in understanding the idea of responsiveness is the idea about expectations. At the very basic level, expectations are individuals' predictions of what is likely to happen in a particular interaction. I give you the example of coming into this lecture. Many of you perhaps had a clear expectation of, okay, what is Sumit going to talk about? Some of you had no clear idea. Some of you went and read about this topic and said, okay, now that I know and I've seen what Professor Ayako has shared, this is what I expect. So an expectation is a reference point against which people benchmark the performance of individual interactants. In the case of health services, individual providers, particularly services and the system at large. And organizational scientists, and I refer to the work of Oliver and Weiner here, they have differentiated between what they call active and passive expectations. They talk about active expectations being those which are at a high level of consciousness, a higher level of consciousness, and are therefore instrumental or key in the decision to use a particular service. Yeah. So I expect to walk into an iPhone store and get the latest iPhone. I expect to go into my GP's office or GP's clinic, and I expect to see a friendly, all-knowing, uh, nice doctor with whom I interact, who knows what I need, and so on and so forth. These are active expectations, which are, which are at a higher level of consciousness. They are up there, and we know what to expect. In contrast, Oliver and Weiner talk about passive expectations. Yeah, these are only generally true assumptions and are not processed unless and until they are disconfirmed. What does this mean? Within the health system context, people may not take notice of, or they may be indifferent to. That is, they may not feel satisfied or not satisfied with the health system until a particular interaction involves some form of confirmation of their active expectation. Example, acceptability of services or a violation of their passive expectations. To give an example again, I walk into my GP's office, my GP's clinic, my general practitioner's, my doctor's clinic, knowing fully well that there will be nobody else there, only he and I would be interacting. But then suddenly I see a bunch of students sitting there. My expectations of privacy are suddenly disconfirmed. Only then do my passive expectations kick in. I say, okay, I expected this. This is not happening. So that's the distinction one needs to make. And that also applies to how people perceive their experience of the health system. And that shapes people's understanding of the responsiveness of the health system. And we will come back to this in a little more detail later in the presentation. And while I'm giving you the example of a clinical encounter, what I'm talking about constantly is the non-clinical aspects of care. Whether my doctor takes good care of me, is he polite to me, is he kind to me, does he keep my privacy, and so on and so forth. We are going to come back to this in a little more detail, but I've introduced to you some adjacent concepts, quality of care, patient satisfaction, which are quite closely related to the notion of responsiveness. And I have also introduced to you an important core feature which underpins the idea of responsiveness. I've introduced to you the concept of expectations, and I'm going to come back to it in a little more detail later. With having done this, let me then dive into the WHO's definition and its elaboration in the form of a framework. I would like to pause here briefly and to see and ask if anybody would like to raise a question, would like to seek a clarification. And what I would like to do is see if some of it is covered later. And if it is not going to be covered later, I'll address it right away. If it is covered later, I'll tell that it will come back later. Does anybody have any thoughts or any questions so far?
Hello, everyone. Thank you for your presentation, Professor. I have two questions about your presentation. So, Professor, I'm from Uzbekistan, and now I am research student in Kyoto University. As you know, Uzbekistan also have a developing country, and not developed country. So what do you think, how many years we spend to increase our health system? Usually, how many years the government, which is some like Japan or Germany, they spend a lot of money for increasing health system. But usually, how many years do they spend this, all of the countries? This is first question. Mm-hmm. And second question, what your recommendation for developing country? First, what we should do in what we're beginning, we must to start. Thank you. Right. This is my all questions.
Right. Thank you, Jasur. If I understand and speak your name properly. So, firstly, let me turn the question on you. I would argue that even Japan is developing. If we were to say Japan and Germany or US or whatever are developed, it suggests that there is no room for improvement. And the last 1 year has shown that every health system has room for improvement. So that's one point I would like to make. How many years does it take? It is an ongoing process, my friend. There are new challenges emerging all the time. And there are old challenges that becomes relevant suddenly. Germany and Japan and the United States thought that they had controlled infectious diseases, and COVID came along. And we have seen what has happened in Japan. We have seen what is happening in Germany. We have seen what happened in the US. So the health system is in a constant process of improvement and development. Of course, different health systems have different challenges. Uzbekistan has its own challenges. Maybe it is still related to accessibility of services. Maybe it is related to quality of care. Every country has to decide and recognize where in the path, where in the journey of a responsive health system or a strong health system they are. So it will take a long time for everybody. It's an ongoing process. What can be done? That's a separate lecture, I'm afraid. And do I have all the answers? Absolutely not. Do I have some suggestions? Absolutely. I will only make one point, that whatever needs to be done has to be decided not by people sitting in Melbourne, Kyoto, Tokyo, Washington, or wherever. If it is Uzbekistan, it is the people of Uzbekistan and leaders like you, Yasur, who have to come together and discuss what do we want for our health system and how do we go about getting it. We can learn from everybody else, but it has to be done and decided internally. So partly answered your question, hopefully. Of course, there's a whole lot of other things that I intend to cover on the topic of responsiveness of health system. So we will return to some of the relevant ideas later. I understood, Prof. Sayako, that there were other questions too.
Yes, I would like to ask Swati-san to ask question, and then we have also comments from Sani-san. He is in the library, so we will read out his question after
Sure.
Swati-san.
Okay.
Swati?
Good morning, Sumit Sensei. Thank you for the it's a very introductory lecture. I have one point in the slide 8. It's about the institutional relationships. So I don't know this is my question or not, but whenever we go to a hospital and there's a number of X-rays or blood tests, whatever the doctors advise us, and then sometimes they don't do the treatment and they refer to some another hospital because sometimes the case is not under their control. So when we go to some another hospital, then they again advise those same tests and those same X-rays. So is there anything that we can do to link this data so that there should be no repetitive exposure for the X-rays or the blood tests? It will cut the medical cost also, save the time also. So there should be something which can relate this, there should be some connection between the hospitals. So at this point, we can improve the design and the function of the institutions. This is my opinion.
Swati, you are right. This somehow links to Yasur's question earlier. So these are the kinds of incremental improvements that can be done to make the system both perform better, to deliver better health outcomes, to perform more efficiently, because with less resources, you can achieve better goals, but also be responsive to the user's expectations. Who likes to be X-rayed twice? Who likes to be pricked twice to collect blood?
For that same information.
Exactly, for the same information. So those are the kinds of things that can help improve in small ways the responsiveness, efficiency, and effectiveness of the health system. Absolutely. How can it be done? There are many mechanisms through which it can be done. In the old days, faxes would be sent. Today, in the time of email, emails can be sent. Today, in the time of information technology, we can have health management information systems through which these things are linked. and people can, different providers can access patients' information directly. There are many challenges around it, and it is beyond the scope of this session to talk about it, data security, confidentiality, and privacy. But that is all part of the conversational mix that needs to be taken into account. But yes, there are ways to approach it. Absolutely.
One more point I would like to mention: this is not about the low middle income country. This is about Japan also.
Mm-hmm.
As a patient, I face this problem, and even though it is a high technology country, but they don't share the data. Maybe they have some internal problems. I don't know about that problems.
Yes.
But this was the problem I faced in Japan also. Thank you so much.
It is not uncommon. It is not an easy task to do. Many constraints to it, indeed. Right.
Yes. Thank you.
Okay, so I want to read out Sani-san's question.
Yes.
He asked that the position of prima facie in medical ethics. Where is the position of prima facie principle in the 7 elements of responsiveness? Can you say something about this?
Okay, that's a good question. And some of it will get answered as I introduce these 7 elements. And I will engage with Sani-san's question. If I don't, please remind me. Is that all right?
I suppose yes. And if anyone else have questions also?
Okay,
so far seems not. So can you please proceed?
I will proceed. Yes. So thanks for the questions, and I'll introduce briefly, and I'll spend some time on this. What is now acknowledged and what is now recognized widely as a almost universal framework for what entails responsiveness, what constitutes responsiveness, what are the elements of responsiveness. And while questions remain about the theoretical validity and universal applicability of the elements of responsiveness, there is agreement that all these elements apply almost all over the world. So the mix of what matters more in different settings may change, but overall, there is quite some agreement that this is all fine. This is all applicable universally, while differences would be according to geographical, cultural, and care contexts. So, and I'll use some of these differences to illustrate my point as I go through each of these elements, if you may. What is dignity? Dignity refers to the right of a care seeker, a patient usually, to be treated as a person in their own right, rather than merely as a patient. So a patient, but also to be treated as a person in their own rights. And it includes the safeguarding of human rights, such as liberty to free movement for individuals, for example, who have leprosy, tuberculosis, HIV, infectious diseases in particular, treatment with respect by healthcare staff, the right to ask questions, and to provide information during consultations and treatments, things like that. It also includes privacy during examination and treatment. So it's something that keeps and upholds the bodily and the identity-related dignity of a person. So an important feature of a element of responsiveness. Autonomy. Autonomy refers to 4 specific rights. The right of an individual to information about his or her disease and the alternative treatment options that they may potentially have. So this relates to the facilitation of informed choice. The second right relates to the right to be consulted about treatment, the right to informed consent in the context of testing and also treatment. And finally, the rights of patients who are in sound mind to refuse treatment. So autonomy is people having the choice and the decision to decide and accept or refuse certain forms of treatment. And Sani-san's question, some of this has come under threat and being challenged and questioned, as we have seen in the COVID-19 pandemic. We have seen people not wanting vaccines. In Germany, 20% almost, if I remember my statistics right from some time ago, whole number of people in USA, for instance, are refusing vaccines. And is it right that they have the autonomy to refuse, or is it by putting the lives of other people at risk that makes it necessary that they should get the vaccine? So complex discussion, but autonomy is an important element of health systems responsiveness. So, and people have talked about different kinds of things in relation to autonomy. Professor Iwakuma has also talked about it in one of her recent works, which I will introduce later. The idea of a paternalistic model of healthcare, where provider makes all decisions on behalf of patient because the provider is considered better informed and better knowledgeable, so on and so forth, the paternalistic model. And it goes against the whole notion of autonomy. The second model is the informed decision-making model, which talks about patients being given the information by the provider and then patients taking the responsibility of decision-making. The third model, which has been introduced here, is the professional agent model. The patient willingly forgoes the right to say, okay, I know, I understand, but I leave the decision to the provider to say, okay, you do what you think is right. I've understood my choices. The final model introduced within the autonomy literature is the shared decision model. And people, that is patients and providers, discuss, come together, come to an agreement and determine preferences and so on and so forth. So a whole lot of attention is now being paid to this topic of autonomy. It has become more important as a fundamental principle in all caregiving encounters and in the responsiveness literature. These are, of course, ideal types, these four models that I've introduced, and how it plays out always depends on where you are. In some cultures, you will definitely recognize that the question of autonomy is also complicated by the need to consider families' views and opinions. It also becomes complicated for patients like who can't express themselves, or small children. And in that case, autonomy is devolved, and who it is devolved to becomes an important discussion. So complicated, difficult concept, but increasingly important within the health systems responsiveness conversation. The third important element of health systems responsiveness relates to confidentiality. It relates to the idea that information relating to patients is private. It should not be divulged without the prior permission of the patient. It also links to the idea of autonomy, that the patient decides what is right for them, what can be shared, and so on and so forth. This is a fairly straightforward idea, but not easy to implement. The fourth major element is prompt attention, and it refers to three characteristics. Very clearly, timely care in emergencies, and care within reasonable periods in non-emergency settings, surgeries and so on, and reasonable waiting times for consultations and treatments. Simple, but very complex, as we will see later. The next one is quality of amenities, and this relates to physical infrastructure, clean environments, appropriate ventilation, water, toilets, and so on and so forth. The next element is access to social support networks during care, family, friends, religious support, and so on and so forth. Those kinds of things. The last one within the WHO framework is choice of care providers. And this relates to both institutions and to individuals who are providing care. And this is an important element of health systems responsiveness, but also a very difficult one. But this becomes increasingly important as all other elements become fulfilled. And this includes the choice of the gender of the provider, the particular provider, if patients want continuity of care, and so on and so forth. More recently, others have elaborated upon these 7 elements, and they have proposed the inclusion, we have proposed the inclusion of trust as an element of responsiveness, an 8th element of responsiveness. It is based on the recognition that trust is an important in determining people's expectations and their decision whether to use a particular health service or not. We have written a paper about it, and I'll return to it in detail a little later. While we note that while high trust can increase and spur the utilization of services, a bit of distrust, particularly if providers are aware that people don't trust me blindly, can catalyze improvements in quality of care, can catalyze improvements in systems responsiveness. Yeah, so the others have talked about coordination. It relates to the idea that Swati-san just mentioned, right? She talked about coordination between different providers so that tests don't have to be repeated, so that referrals can happen smoothly. All this becomes a part of the institutional arrangements against which responsiveness is assessed, about which responsiveness is all about. Yeah. Now, I've introduced this framework to you. I've talked about this framework. And before we proceed further to discuss the implications of this framework, I would like to point out that it raises many different questions. But I would also like to draw your attention once again to an important aspect of the definition. You will recollect from the definition that responsiveness about a system meeting the expectations of people and the legitimate expectations, universally legitimate expectations of the people. The key word here, once again, is expectations. So I want you to think a bit about the many ways in which expectations can be, you can make sense of these expectations. And I want to draw your attention to something that Professor Iwakuma has written. So she's written a very insightful piece here, where she has written about the famous Japanese medical TV series, and I must read the name here carefully. The name of the TV series is Shiroi Kyoto, translated as the Great White Tower. And it is based on a novel by Toyoko Yamazaki. The novel was dramatized twice, yeah, and first in 1970s and again in 2003. In the paper, she examines the two iterations of the dramatization, and she talks about how the clinical communication aspect of the interaction, specifically the doctor-patient communication, has changed and how it has evolved over time. So she points out, if one reads between the lines, that the interaction between doctors and patients, we see more accommodation for and greater and higher patient autonomy becoming the norm. The norm shifting from a paternalistic model to a shared decision-making model. In line with what Professor Iwakuma is pointing out, while she's focusing on the doctor-patient communication part of it, in our forthcoming paper, we develop in detail, it should come out in a month's time, the idea of expectations in healthcare. And what we propose there is, we are calling that an intersectional, translocational, and relational analytical framework for understanding patients' healthcare-related expectations. And the translocational also refers to temporal. Over time, these expectations and models change. Yeah, and all these, what are the dignity-related expectations? What are the autonomy-related expectations? What are the attention-related expectations? All of this changes as one moves from one place to other, whether it is Swati-san coming from India to Kyoto. She comes with a preset set of expectations. Whether it is Yasur-san coming from Kazakhstan to to Japan. Over time, things change. I have a PhD scholar who's working on it, and I'll share some details later. So that complicates further the kinds of implications it has for policy, practice, and also research. I will pause here for a bit but we will return to the idea of expectations again in the sections that come in later. So what we will now discuss are some questions for policy, practice, and research that the concept of health systems responsiveness triggers. This should be of interest to the faculty members who happen to be here, but it should also be of interest to students who will return to their countries or who will join the public health, the practice field within Japan or in their home countries, and also some of you who might carry on to become health policy and systems researchers. Depending on how you look at it and depending on your role, whatever it might be, there are interesting challenges and opportunities. One of the interesting challenges relates to the applicability of this framework and the mix of different elements of health systems responsiveness. As I've discussed earlier, some critics have questioned the validity of the use of a single framework or a single composite score to study health systems in different societies. Societies which have different cultural, different economic, different political, different health system structures. So that becomes an important question, both for policy and practice, but also for researchers. This is the basis for one of the studies that we are currently doing in Ghana and Vietnam, where we are comparing the health system's responsiveness to the needs and expectations of pregnant women who have mental health issues. There are questions of applicability of this framework to different contexts. Another interesting line of inquiry and another interesting implications for policy and practice relates to the meaning of each of these elements. We have talked about all these elements. What is dignity in Japan? Is it the same as dignity in Uzbekistan, Kazakhstan, India, Nepal, Vietnam, Australia? Are the understandings of confidentiality different? I will go one step further. I would go, one can also have different understandings of different elements across different care contexts. Is dignity the same in a general practitioner interaction? Is dignity the same in a general practitioner interaction and a laboratory X-ray setting? Is it the same in an intensive care setting? Is confidentiality the same in these settings? These are important things to consider as one talks about responsiveness from a policy design, policy implementation, and practice orientation. And if we don't have these answers, these become important research questions. I draw your attention to an important and very complicated feature of the definition. The notion of legitimate expectations, the notion of legitimacy, and the notion of a universally legitimate expectations. If you remember the definition, it talks about responsiveness to universally legitimate expectations rather than to individuals' expectations, because individuals' expectations are very personal. They may be societal, but they are very personal. The argument that this definition makes and the whole concept makes is that having universally legitimate expectations will allow one to assess responsiveness across health systems. It throws up many issues. How does one arrive at? How does one decide what is legitimate? At what level should this demarcation of legitimacy occur? At the global level, national level, local level, service type, tertiary, secondary, primary care, different kinds of services, emergency services, outpatient services, inpatient services. How can one accommodate such diversity? You will recognize that there will be different expectations which are legitimate across these contexts. How can one accommodate it in any effort that tries to define and specify what this means? Diversity across countries, across social groups, men, women, adolescents, elderly, married, unmarried, gay, not gay. All of this becomes complicated, difficult in terms of policy and practice. This is an important challenge, but it also produces and creates opportunities for research. Yeah. we have to recognize that the individual expectations which are related to satisfaction are intimately connected with the universally legitimate expectations that the definition of responsiveness is talking about. And the individual's expectations are somehow aspirational. What I wanted today, I want more later. And one cannot just say that, okay, just because Sumit wants something, it's legitimate or not legitimate. We also want to look at how we develop things further. Expectations also evolve. So as Yasur was saying, development is continuing. Improvements continue. So expectations must keep track. They must keep matching. So from a research and comparative research perspective, these become very challenging issues. And all these issues apply to all the 8 dimensions. And sometimes, as somebody who studies and works on and thinks about this subject, I even wonder whether it is possible to even do comparative research at all. And that's what we are trying to do in the kinds of studies we are implementing at this stage. I want to pause here very briefly. We want to keep this lecture within time, but if people have any questions, I would like to take them now. We've got 30, 40 minutes, 35 minutes still. We can use the question time and the session efficiently. Please feel free to share your thoughts. And I want to give some examples about how do you demarcate legitimacy. But if you've got some thoughts already, I would like to hear some of your reflections. If I'm making myself clear, if you want any clarification. Yes.
Thank you. And let's ask everyone if you have some comments or questions. And also, Sani-san have another comment, so I will read first on behalf of him. He says, Prof. Kane, in my opinion, the elements of 7 elements of responsiveness is narrow. Many aspects that are not included in the element. For example, demography, the gap of health service between remote, rural, and urban area is different. Thus, will influence expectation of the individuals. Can we widen the scope of responsiveness by demography, for example? I want to know your opinion about gaps of health service in rural and urban related to responsiveness.
Right. Good. I think this is a good question. My answer to whether demography can be included in these elements, the answer would be no, but yes. How is the question? What Sani-san, you're trying to say is that these expectations vary by geography. You are absolutely right. But the elements that constitute a responsive health system doesn't include demography. How they apply to different demographies is probably what you mean. What is a responsive health system? What are the expectations? Varies by different demographic groups. For a young person, it's different. For a middle-aged person, these expectations are different. Expectations around dignity, expectations around confidentiality, expectations around accommodation and amenities. They would be very different for the elderly. And I think I understand where you're coming from. I have just begun a project which is trying to understand, this is something we're doing in India, trying to understand the responsiveness of the health system to the needs and expectations of the elderly. India is rapidly aging. Many parts of India are becoming quite close to how Japan is at the moment. But our system does not recognize the fact that such a large number of people are elderly. So we are trying to understand from a policy analysis orientation, where is the policy response to the aging population? Is it responsive to the needs and expectations of the growing elderly? So in that sense, it is possible to expand the scope of what those elements are, and I invite you to conduct research to say, okay, what is it unique? What is unique for the context of Japan, maybe context of some another country that should also be there? I can warn you that as we were writing our paper for the inclusion of the idea of trust as an element, even I had doubts, and I still had doubts whether it fits. And if you read the paper we've written, you'll recognize the kinds of things we've raised there. Adding an element is possible. It has to be very well justified. And I would invite Japan to construct its own idea of what they think are elements of responsiveness. Any other thoughts?
Thank you. I'm Takashi from Medical Communication. And now I've got to know about responsiveness. I kind of think that all countries, including Japan, are developing in health systems responsiveness. And we need cross-cutting understandings and cooperation. And as a medical communication student, I'd like to ask you, do you have any advice about the most important point we need to share in responsiveness when we communicate this concept among different people, not only health researchers or health experts?
Yes. Takashi-san, this is I couldn't agree more. I agree with you that this is an important area of common interest across countries. And different settings, different contexts will have different things that are important. And I will share a few examples with you. And I use the liberty of returning to my talk because you have raised a point which is, how should I say, which allows us to start understanding that it can be different in different settings. Take the example of waiting times for elective procedures in hospitals, right? If you are talking to a hospital administrator, if you are talking to policymakers, it is important to understand that they are concerned about, say, for cataract, the surgery for eye. What is a reasonable waiting time? In many countries across the world, we have seen this debate going on about what is a good waiting time. Is it 3 months? Is it 6 months? Is it 1 year? There is no agreement on it. But the important principle is exactly as you say. People may have different views on what is a reasonable waiting time. The key question is to have a conversation about waiting times. The key point is that to have a consensus-based conversation about waiting times, not only an economics-based or a narrowly policy-focus-based conversation about waiting times. In other services, Takashi-san, it's easier, right? For instance, trauma services. Waiting time agreement is simple, right? If somebody breaks a leg, we know that we will not be waiting for a long time. Isn't it? So in every field, in every area, there is room for a conversation. What constitutes a pleasant environment? It will vary depending on people's aspirations. But it's an important conversation. Am I engaging with your question in some way?
Yes. I'd like to keep thinking more about the idea of responsiveness. And actually, Professor Miho Yakuma introduced this lecture to me, and I'm being really impressed today. Thank you.
Right. Okay, thanks. I want to build on what Takashi-san has raised now, and I want to share a couple of examples in some ways. Yeah, I've talked about elective surgeries. I've talked about emergencies. I've briefly introduced the idea of what is a pleasant environment. We can also talk about facilities this way, right? Should all facilities have ramps? The sliding way to walk where you can roll a wheelchair, when in fact there may not be enough money or resources to change the existing infrastructure in many low middle income countries, or there may not be enough resources to build lifts to accommodate for the needs and expectations of those with physical disabilities. How do we have those conversations? These are important policy and practice related questions which have a bearing on the idea of responsiveness. Is it legitimate to have these expectations? So the policy and practice related expectations and challenges are understandable. They can be foreseen. You can anticipate, all of us can anticipate. They're somehow obvious. But the challenges around research, as probably Takashi-san was also alluding, particularly around comparative research and cross-country research, are quite complicated. They are slightly more difficult. And I will briefly touch upon these here. I want to introduce some ideas that have been introduced to say, okay, how can we do cross-country research on responsiveness if so much of it depends on what people in each country think is a legitimate expectation, right? So from a health systems responsiveness research and a comparative research perspective, and to enable comparison, a zone of tolerance approach has been proposed. This idea attempts to take into account that there tends to be a zone of tolerance around what people tend to expect from services. I take a simple starting point. People's expectations around the kinds of physical amenities and infrastructure might vary from context to context, and that people recognize that resources that are available to them are limited, and they tailor their expectations according to their understanding and their cultural understandings. So people who have proposed this idea of a zone of tolerance to allow country comparisons, context comparisons, say that you can also use this to compare different kinds of services. The example that is given typically relates to beds in a hospital. If you look at many parts of the world, sleeping on the floor at home is normal and perfectly acceptable. And it is always done since we sleep on the floor in many parts of the world, right? And people will not take offense if they are asked to also sleep on the floor in a hospital. The question then becomes, is it reasonable for some people in the hospital to have a bed which is standing on high, and others have to sleep on the floor if the hospital is crowded? If there are not enough resources, if there is not enough money, if there is not enough space for everybody who comes to a crowded hospital in a low and middle income country contexts, is it okay? How tolerable and how legitimate it is for some patients to have floor beds? To accommodate for these real life situations, and this is a simple example, of course, this zone of tolerance approach has been proposed because it relates to a social norm. This is a simple example which is possibly socially accepted in some countries. However, the same cannot be said for other elements of responsiveness, right? Dignity and confidentiality. I would expect that the zone of tolerance around dignity would be very narrow no matter where you go. In some countries, the zone of tolerance around dignity might be extremely high. People would be not willing to compromise on dignity at any extent, no matter where you go. So it depends on the element that one can use this zone of tolerance approach for comparative research, if I understand the question right, and I wanted to touch upon it anyway. But one has to also realize that the whole notion of zone of tolerance is potentially also problematic from a policy and practice perspective, because it creates the risk that it is manipulated to indicate that something is acceptable for somebody and not acceptable for others. And it creates the possibility that, oh, it's a poor country, you can have this, it's fine. Nobody has a good toilet anyway, so they can live with dirty toilets and so on and so forth. Yeah? So one has to realize that there are limitations to this idea of zone of tolerance. Other research is required, I think, which may have a comparative element, but also recognizes and emphasizes a specific element. And I'll introduce some of the possibilities and some of the ideas in the next slide here. Here, I talk about a whole range of research questions around what all shapes people's care experiences, expectations, and responsiveness. We have proposed this framework in a paper we've written in 2017. Different aspects of the framework, if you note, they lend themselves to meaningful and very useful, I think, and very practical research in public health in different parts of the world, including Japan. From small projects to large projects, research and inquiries focused on different care domains. We can do it in different settings: primary care, secondary care, tertiary care. We can look at maternity care. All of this can be done. We can focus on the interaction, larger projects. We can look out on the left side, which is what do the policymakers, managers, service providers think is possible in terms of dignity, autonomy. What do they think is going on? We can conduct surveys. We can use a whole range of approaches, quantitative, qualitative. We can draw on many different disciplines. And I turn to Takashi-san's question once again. For instance, to give an example, it is perfectly possible to conduct anthropological or ethnographic or sociological inquiry into understanding what does dignity mean in different care settings. What does dignity mean in Cambodia? What does dignity mean in Ethiopia? What does dignity mean in Japan? And how are they different? What does dignity mean in an emergency setting? What does dignity mean in a laboratory setting? For instance, in a maternity setting, what happens to how people expect to be treated in terms of dignity in different settings? What do families think about it? What role do families play? What role do social norms play, communities play in shaping these expectations, in shaping the experiences of care? So one can approach this subject in terms of research from many different angles. One can approach it to understand what is feasible, what can we do, what goals we set for our health system, and how do we work towards it. So we argue that this framework allows a whole bunch of things to be imagined in terms of both research and also in terms of policy and practice. As I come close to finishing my talk and making my point, I hope I'm doing okay with time. Let me see. Yeah, we've got 10 more minutes. I would like to share with you how we are, with concrete examples of how I am trying to do some of those things, some of my ongoing research. One of my PhD students is working on theorizing and proposing a conceptual overview, presenting a conceptual overview of healthcare-related expectations. We are suggesting how could one go about studying healthcare-related expectations. She's conducting an empirical study on recent migrants' experiences of the Australian health system. And she's trying to see, okay, people who have come to Australia within the last few years, how do they experience the health system? Does the system's understanding of what are legitimate expectations matching with their expectations? And what can we do to improve the Australian health system's responsiveness? I've talked about the study in Ghana and Vietnam, where we are comparing different meanings and understandings of different elements of responsiveness. And we are comparing what enables the health system to be responsive to the needs of pregnant women who have mental health issues. A PhD student who has just completed her research has not explicitly focused on responsiveness, but a whole lot of her findings have implications for the responsiveness of Pakistan's health system to those suffering from multi-drug resistant tuberculosis. And as I said, we are beginning a study which is trying to unpack and understand the responsiveness of the health system to the needs of elderly in India, in the state of Tamil Nadu, where we have a rapidly growing population of the elderly. What I've shared today and what I've discussed so far, I think, and I'm sure you would all somehow agree, is not just important in terms of recognizing and appreciating this subject as a public health practitioner or policymaker. It also lends itself to meaningful and very useful practical research in the field of public health, no matter where you are in the world. I hope you found this session useful, and I hope I have been able to spark some interest in the topic of a responsive health system amongst the many of you who are here, who are thankfully attending the session today. I also hope the challenges that I have shared don't appear too daunting. Challenges both for policy and practice and for research on the topic of responsiveness. They don't appear too daunting, and they in fact amplify your interest and encourage and spur some of you to tackle the many exciting research opportunities and questions that this topic lends itself to. Finally, I would very much like to hear from you, both the faculty members, postdocs, students alike, your thoughts, your ideas, your criticisms, and I hope we can do some exciting work together, and I can contribute to developing some of the ideas that you might have emerging from this discussion. I will stop sharing my screen. Thanks once again. I have my email ID there. You can also find me on my university webpage. Thank you so much.
Thank you, Professor Kane. And now we still have about 10 minutes, so let's just have some time for questions and comments. Anyone have comments, questions? Nakanomari-san.
Thank you very much. Now, this is just a comment. I'm sure one of the keywords maybe are expectations, and I think it's important to have conversations, and as you said, and we need to try to make discussions and expectations very active. I really appreciate your lecture. Thank you very much.
Thank you. Thanks for the kind words, and you are bang on. The key question, the key issue, the key point, the centerpiece of this whole conversation is indeed expectations. And that is contested, that is controversial, that is challenging. And what is a legitimate expectation? Who decides? Are we even having a meaningful conversation about what are reasonable and legitimate expectations? Are we engaging with those whose expectations are being met as a health system? As health systems researcher, are we even asking these questions? Is there a disconnect? Is there a connect? How are they aligned? I think these are really exciting questions which we all of us can meaningfully engage with, no matter where we are. Yeah.
Thank you.
Yeah.
Any other comments, questions, Swati?
This is just a comment, Sumit Sensei. I think the doctor-patient communication is also related to expectation. I believe doctor-patient communication varies as the field of the doctor. The pediatricians are more communicative if I compare with neurosurgeons and cardiosurgeons. The patients are always confused. They don't know what to speak and what to say. So again, then they are left back with the passive expectations which are not fulfilled.
Right. That's a good point. I would qualify this, Swati. I would go.
Yes.
Um, there is a historical tendency for certain certain types of care providers to be not so
Yes.
good at communicating, right?
Right.
Right. The good news is, and this is something that is borne out in uh, Professor Miho's paper that I talked about, that
Yes.
things are changing. Even this, all professions, all subspecialties. I'm a dermatologist by training, and
Okay.
I've seen this change happening. For whatever reasons, there's a whole range of reasons. Some of it is driven by litigational threats. Some of this is driven by internal conversations within the profession. Some of this is driven by Google, right?
Okay.
People go and find, and they are better informed, and that makes life easy for doctors, not so easy for others. But there are also some peculiar disciplinary processes which will take time. But there is a change that is happening in terms of doctor-patient communication. Our role as public health experts, policymakers, whatever we become, practitioners, researchers, is to contribute to this conversation, saying that, hey, listen, there is room for improvement here. The developing and developed conversation comes back, Swati. Does that make sense?
Yeah, exactly. You are right. It is definitely it's improving. I also believe so.
Yes.
Agree. Thank you.
Okay, anyone else? Maybe someone who haven't spoken yet? Yes, Miss or Mr. Mutanov.
Hello, everyone. Thank you, Professor, for your nice presentation. I have a question about, can we use statistical data to evaluate the health system responsiveness? Maybe this is a little bit the indirect way. For example, if we want to evaluate emergency unit responsiveness, for example, how many people applied with cardiac arrest and what's the outcome from this, how many people died and how many people still alive from the outcome, what's the outcome? Is it possible to evaluate using statistical data? For example, two countries data is different in Japan or the other countries. For example, how to evaluate the system by using about the illness and incidence of some disease, or just using statistics. Is it how do you think about this point?
This is a very good question, Babur.
Thank you.
I think a whole lot can be done here. Yeah, there are, and certain elements of responsiveness, Babur, particularly, lend themselves very nicely to statistical analysis. Of course, a lot depends on the availability of appropriate data. And the good news is you can use service data to raise questions and not necessarily to provide answers. And raising questions about responsiveness using statistical data is an excellent starting point. The example you gave, however, probably relates more to quality of care rather than to responsiveness. But the same example can be turned around slightly. If somebody experiences a cardiovascular event, from the moment of you can have statistical data about, if it is possible, about a bunch of time points. From the moment they experience it to the time taken to reach the facility. From the moment they reach the facility time taken for them to be first seen. From the time taken for them to be first seen to the appropriate intervention happening, and then the outcome, which is distant. But till these different moments, each of them reveals something to us about the responsiveness of the health system to the needs of the population, not the individual. The individual has only one expectation. It's a good example because everybody would have the same expectation here. It's universal. I want to get there quickly, that particular window of time. I want to be treated on time and maybe live, right? Yes. So you have a whole bunch of possibilities around using of routine service data and to statistically analyze it to reveal certain questions. Hey, what is happening? So, but there are other things which are slightly difficult. Confidentiality, for instance. So, but for some, it really lends itself very nicely.
Thank you for your answer.
Yeah.
Thank you for presentation.
You're welcome. Yeah. Thanks. Good question.
Okay, maybe we can take one more last questions if anybody would like to comment or ask questions. Maybe I would like to also ask questions. I think everyone, including me, is very well aware of the importance of health responsiveness, and it has a lot to do. We have many challenges we have to face, but think about what would be the incentives or the advantages from the health provider's point of view. Can you give me any of your ideas about this?
Yes, thank you. Thank you. This is an interesting question because in writing the grant applications that have led to this research studies, we have built our argument around exactly this. Yeah, a system that is responsive to the needs and expectation of the population is in the interest of the health system, but it is also in the interest of our political masters, right? If the population thinks that they have been consulted in setting the standards for what is legitimately accepted at a social level, and then those standards are met, then the population is likely to think that our leaders, our political masters, are doing the right thing. I also research, as part of my research, do research on violence against doctors in India. Yeah, in the last 10 years, we have seen a whole number of incidents where doctors are being beaten up, their clinics are being broken down, and so on and so forth. One of the arguments I make is that this is a mismatch of expectations. And research into an active engagement with the population about what should be a reasonable expectation, given what we are, given our health system, will allow this conversation to happen properly, the providers and the health system to better meet these reasonable expectations, and also satisfy our leaders and political masters.
Thank you very much. That gives me more ideas about how difficult, and still we have to take a long time discussing about this issue in the society.
Yes.
Okay, so it's almost time. So thank you so much, Professor Kane. We learned a lot from you, and hope that we have another opportunity to get to know more about. And so once again, we would like to thank you. And if some of you participants can show your face to thank Professor Kane.
Thank you.
Okay, so this is end of the short course. Thank you so much.
Thank you. Thank you, everybody, for attending. It's been a pleasure.